Professor Johansen, if you could run up to the stage, that would be great. Chris spoke before about avoidable harms, improving lives, and reducing, I suppose, functional deficits and frailty. Antony, missed opportunities for prevention?
Hello, it's great to be here. It'd be nice to have some slides. Okay, 18 months ago I stood up and presented this lot. It was a review from the Falls and Fragility Fracture Audit Programme, pulling together what we've done in terms of inpatient falls, fracture liaison services and hip fracture. I haven't brought it this time because you don't need to look at that. All of those audits are now producing data that's much more easily accessible by going straight onto the internet. So if you want to know some of the numbers for your hospitals for hip fracture, and every grant application I read says lots of people die of this, it's a very expensive condition because of hip fracture. Hip fractures dominates all of everybody's thinking. If you want to know about hip fracture, just go to the NHFD website and you can pull down information like this, which really gives you exactly what you need to know. Very simple figures. So we've got 4% of hospital beds occupied by people with hip fracture. So that's pretty much every ward in the country equivalent to one of those beds being occupied by somebody with a hip fracture. That's an enormous resource implication, and you've seen the figures for individual hospitals over the course of the slides are going forward on their own, which is exciting. I'm not entirely sure why. And we've seen how the economics of that work out from the calculator here. The principle that investment of a little bit of money will save an enormous amount of money further down the line. These are figures from the NHFD giving you a sense of quite what's achieved in hip fracture services. So we've heard about fracture liaison services, largely talking about the community population of people who are picked up and seen in fracture liaison services around the country. And we've heard that some places don't have a fracture liaison service, but I would argue that everywhere has a fracture liaison service. All of your health boards have got one or more fracture liaison services. They're really focused on hip fracture, but the hip fracture performance figures are really very impressive compared to those for fracture liaison services in the outpatient setting. We're getting huge numbers of patients identified who've had a hip fracture and are treated and supported or put on long-lasting therapy to protect them over the years ahead. So we've got 1,200 patients in Wales we know have left hospital having had a hip fracture and established on therapy. There is a missed opportunity. There's a proportion of patients who aren't, and you can see that that's probably confined to a couple of hospitals which don't really have established inpatient orthogeriatric services. But the figures look really very impressive. The vast majority of patients in Wales are now getting treatment, and it sounds encouraging. When you compare it to what's going on in the fracture liaison services, which we've been talking around the country, the attainment of the 80-50-80 objective is pitifully smaller. So we've got about a fifth as many patients being established and maintained and supported to continue on osteoporosis treatment by fracture liaison services or by the fracture liaison services for which we have data at the moment. So hip fracture services, as in so many respects, have led the way in the implementation of new ideas. And that's something that we should be very proud of. But what do we tell her? Because we have a duty of candor. What do we tell her about her prevention of her fracture? Could this have been prevented when she comes in with a hip fracture? And we know, you've heard previously, that half of patients who present with a hip fracture have already had a fracture. So we know that half of the people who attend my care, somebody could have known that they had a fracture previously. And we can look, and this data is again reasonably easily available for each of your hospitals. You just have to talk to your NHFD lead in your hospital, and you can pull down the individual data, which gives you a sense of what's going on in individual hospitals. This is the picture for the whole of Wales. So we had 4,200 people last year with a hip fracture. And what you can see at the bottom is that 3,600 of those were not taking anything when they came into hospital. So 6 out of 7 patients were not on treatment to prevent a hip fracture. So that's where the duty of candor kicks in. 6 out of 7 patients we should be approaching and talking to. About half of those patients will have had a previous fracture, and I think there's an argument to be made that so 2 of every 7 patients who I see, I should be apologising to them for the failure of systems to prevent the hip fracture that they've attended with. So we've got a challenge that she's placed on us. The next question, her next question in terms of her bones is, are we going to do something to prevent the next fracture? And we've heard again that 1 in 4 of these patients are going to go on to have another fracture, most of those in the course of the very near future. So she's an imminent risk of fracture. Is something going to be done about that? And the way that the NHFD reports all of that is to give you a sense of what all the hospitals in the country are doing. And this is a really useful graph to look at exactly how your hospital is performing. And there is a range on this graph from 0 for some hospitals in Wales right up to about 75% of patients being offered secondary prevention and being known to be on secondary prevention 4 months later. So that as a picture, if you want to put that in, you put your own hospital's name in, it'll give you a graph showing you and your managers exactly how well or how poorly your hospital is performing compared to the others around the country. And we can summarise the results of that using this table, which is also on the NHFD website, which gives you a sense of how individual hospitals are performing in terms of secondary prevention following hip fracture. So there's a lot of variation, enormous variation around the country. These are the most recent figures for the last year, which haven't been published, but which you can pick up off the website if you want to look at them. So there's huge variation, and we've got areas in which inpatient secondary prevention is still working to catch up. And this is the national picture of what's being done for patients with hip fracture. So this isn't just confined to Wales, but the Welsh hospitals are dotted pretty much across this spectrum. This is how we approach secondary prevention for people who've had a hip fracture. So that's that 1/5 of all fragility fractures. This is what we do. As you can see, most of that page is white. It's blank. So the standard treatment of secondary prevention for somebody with hip fracture is nothing. Included in nothing is, as Kasim said earlier, calcium and vitamin D, which doesn't work. We know that's inadequate. So the standard treatment is nothing. The grey area is definitely a grey area. The grey area is essentially alendronate. And we know that most of the people who we start on alendronate as inpatients in hospital do not continue it. We've had follow-up of our patients. Adrian Turk, who works with me, did 30 years of ward rounds together as my prescribing pharmacist, followed up huge numbers of patients who he'd done everything possible to support their continued persistence with alendronate, and demonstrated that only 1 in 4 of them were still taking it at 4-month follow-up. So alendronate doesn't work. So essentially, 2/3, 3/4 of that page is blank. Standard dose of any treatment following hip fracture is nothing. And then there's this blue triangle, which we can see. These are the injectable therapies. Essentially, denosumab, alendronate, a little bit of PTH being used. So there's a lot of variation in what's going on there. So Kasim's hospital, 1 or 2 Welsh hospitals are right over on the right-hand side here, but then there's enormous variation in what's going on between hospitals. And we need to challenge that. And one of the ways in which we've done that is that the NHFD has a key performance indicator which asks whether you know that your patient is on an injectable therapy and therefore continuing on therapy, or whether you've followed them up to prove that their alendronate is still being taken at 4-month follow-up. That's our key performance indicator 7. It's deliberately pushing for patients to go on to some form of injectable therapy, not oral therapy. And we're seeing this graph rising on a day-by-day basis as a consequence of hospitals picking up and trying to run with that as a process. How should they do this? So 18 months ago, Kasim and I used to send each other emails on a day-by-day basis. And each email started, yeah, okay, but... and it went backwards and forwards, and we never came to any clear conclusion. So we thought we'd get a consensus by, sorry, slide, that's not touching, get a consensus by getting some grown-ups in. And we got the leads for various audits from England, Wales, Scotland, Ireland, to come in and think about the implications of trying to use zoledronate in the hip fracture population, because we know there's a randomized controlled trial of this population that has delivered huge benefits. And all we need to do really is to implement that trial. So why not implement that trial? We'd implement it, Mike and I had implemented that years ago in Cardiff. And it's eminently doable. It's an easy drug to use. But people have a lot of questions about it. I'm not going to take questions about zoledronate now because there are dozens and dozens of questions. But those questions have been worked through. We've worked through them in Cardiff. Others have worked through them in other hospitals. And the fear that people have about using zoledronate and using zoledronate more aggressively than it's licensed to be used, so using it in people with a creatinine clearance less than 35, all of those issues are addressed in this paper, which you should go away and look at. Because it's rationalized the use of zoledronate to make it a first-line agent for patients coming into hospital. So much so that in my hospital, if the house officer is called down to casualty to see somebody as a blue light run down to casualty to retrieve somebody and get them up to the ward within 4 hours, one of the things they do while they're down there is they start the patient on vitamin D supplementation with a view to and prescribing zoledronate. So this is now no longer being prescribed by consultants and independent prescribing pharmacists who's retired. This is being prescribed by house officers. And we've moved to a point that my role and the pharmacist's role on the ward, Will, Kath and Dav's role on the ward, is to think, okay, so we've got everybody on zoledronate who we can possibly give to zoledronate to. What else might we be thinking about doing that might be better than that? Should we be referring them on for consideration of other therapies? Are they somebody who would be fit enough to come back and perhaps be taught how to use denosumab? But the baseline therapy is that pretty much everybody should be considered for zoledronate. You can't get everybody on it. You can get 3/4 of people on it, but renal function issues top the curve out at about that point. And the trend in the use of injectable therapies and this upward curve in the key performance indicator 7, so patients who we know are on treatment 4 months after their fracture, is encouraging, and even more encouraging if you look at the Welsh performance. So we're outperforming the rest of the UK on this one. We're doing that, and there's a lot of zoledronate being used, particularly in Inda's patch, our patch, but around Wales we've got really very impressive figures. And we're in a position to reassure her that things are going to be better. Can we extend that beyond hip fracture? Well, the inpatient orthogeriatric service may or may not be involved in patients who don't have hip fracture. The NHFD has extended its remit to look at fractures anywhere else in the femur. So we're picking up patients with periprosthetic fracture. There's several thousand patients with periprosthetic and distal femur fractures around the country who are now being swept into our ambit. And those patients we're starting to see going on to therapy. If you go to the NHFD reports, you can download information about the other fracture sites that we have, and you can start to see performance figures for individual hospitals. And you can see that substantial numbers of these patients are also being offered appropriate injectable therapies to try and change their risk of future fracture. So we've extended throughout the whole bone. That's the orthopedic surgeon's definition of holistic medicine, is we're treating the whole bone now. We want and we need to extend it beyond there. There are a lot of other patients who are in hospital who are not captured by the NHFD, are being seen by orthogeriatricians, pharmacists and teams around the country while they're in hospital, and ensuring that those patients also get treated is important. And of course, within the hip fracture population, many of these people are so frail that coming back for second doses of zoledronate, coming back for outpatient support and follow-up is not going to be a realistic option. But when you start moving into other populations, you've had an increasing proportion of people who would be appropriate for work with the fracture liaison service, and trying to integrate the the measurement of fracture liaison services with hip fracture services is something that CASIM has in hand at the moment, so that individual hospitals and health boards are able to look at what their performance is like, not just on their community population, but on both community and inpatient population, to try and make sure that the total numbers really start to go up, because we've an enormous missed opportunity otherwise. If you want more detail of how we do it in Cardiff, the YouTube channel will give you a really clear picture of how we do it, and an explanation of the Zeledronate argument.